I'd like to introduce our judge for today, Ms. Vardeep Diogan, Senior Continuous Improvement Manager, North Bristol NHS Trust.
Fab. Lovely. Thank you, Noah. And hello, everybody. So we can see from the list there's going to be 10 posters that will be presented in this session. And we're going to have 5 that are presented first, followed by a short break, and then we'll have the remaining 5. Each of you, and you've already been sort of up to speed on this, each of you will have 2.5 minutes to present your slides. And then following that, I will then be asking you some questions for up to 3 minutes. Timekeeping is just really important here for fairness. So please try your best to keep to time. And we'll sort of manage that accordingly. And Noah will probably say more about that in a moment. As a presenter, you're expected to stay here for the whole session. Obviously, you now know the order of which you're going to be presented, and the winner and the runner-up of this group will be announced later on today on the main stage at 5 o'clock. And I just want to, before I hand back to Noah, I just want to add one small thing. So as Noah said, I'm from North Bristol Trust, and it may be that 1 or 2 posters in this group are also from the same organisation. And I just want to say, for transparency and fairness, they're not pieces of work that I've been involved in. So I'm looking at all of this from a sort of neutral perspective. So I just wanted to say that for transparency. Over to you, Noah.
Brilliant. Thanks, Vardeep. So just to clarify, I'm managing the slides. So if you could say next slide as necessary to move on from your first to second slide. As our judge has just explained, you are expected to complete the presentation within the allotted time, and I will call time at exactly 2 minutes and 30 seconds. I will then invite the judge to ask questions for up to 3 minutes, and we'll give a verbal 30-second warning before calling time on that 3 minutes as well. We'll then have a short pause while the poster presenter who's finished mutes their mic, and the next presenter or presenters unmute themselves. Now, everyone apart from the judge and the presenter of the first poster should have muted their audio, please. Dr. Niharika Singh will now present on tackling tablets in trauma. An accessible cheat sheet sustainably improves the understanding of perioperative medication management in doctors clerking and acute orthopedics. Take it away, Niharika.
Hello everyone. So my name is Niharika, one of the Foundation Year 2 doctors at North Bristol Trust, and I did this quality improvement project with my colleagues on the Trauma and Orthopaedic Department. And as mentioned, it was on tackling tablets in trauma. So going on to what we did. So we identified the importance of perioperative medication management in the acute orthopedic trauma, especially due to our increasingly complex patient population with polypharmacy and associations with poor perioperative medication management and morbidity and mortality, as well as more costs to the trust. So we identified that most of the doctors who were clerking in these patients were pre-specialty level doctors, so resident doctors, who often rotate and may have poor knowledge in perioperative medication management, which could lead to avoidable error. So our aim was to sustainably improve the understanding of perioperative medication management in these orthopedic clerking doctors. And the way we did this is for the Foundation Year 1 to Core Trainee 2 doctors, we asked them to do sequential quizzes assessing their perioperative medication management knowledge in common cardiac and diabetic medications. We used plan, do, study and act cycles to assess knowledge at baseline, following our first intervention, which was a teaching intervention within our department. Then following the release of a cheat sheet, which is available on phones and office walls, and is also shown on our poster, and then following staff rotation. Next slide, please. So going on to outcomes and what we learned. So the information we got was very interesting. So the baseline knowledge in these clerking doctors was they had about 58% correct answers, which was quite poor to start off with. After we did our teaching intervention, this increased to 72.7% correct answers. And then following the release of the cheat sheet, this again increased to 95.6% correct answers. And what was really interesting was following staff rotation with the use of this cheat sheet that we had produced, this sustained a 91.9% correct answers. So to conclude, all the interventions improved the perioperative medication management. However, the impact of an accessible document outlives the rotational nature of resident doctors, showing that there was sustainable knowledge transfer, and this QI project will retain within the department. Thanks.
It's time. The judge will now ask you some questions.
Brilliant. Thank you. Thank you for going first as well. A couple of questions. Did you notice, were there any themes that came out of the gaps in knowledge from the initial sort of baseline knowledge survey that you did?
Yes, so I think one area that was particularly found to be poor knowledge was diabetic medications. And so people found it very difficult to know when to stop certain diabetic medications and when to restart them, but also with insulin. And I think what was really interesting in this scenario was, after talking to a lot of the consultants on the ward and orthopedic doctors who were at higher levels, not a lot of people knew that there were guidelines within our trust, on the trust guidelines, about diabetic medications and insulin management in people who are unwell or going for surgery. So I think putting into a document just made it more accessible for people and actually highlighted that those guidelines were already there.
Okay, so some of that was signposting.
Signposting, yes.
Yeah. And then with your cheat sheet, did you get it right first time, or did that go through various iterations?
So I think we were very lucky that we had some consultant geriatricians and consultant anaesthetists who we got involved in making this cheat sheet, as well as getting information from other doctors and the orthopedic doctors as well. And
Yeah.
it did go through many cycles, and we were going back and forth to what the anaesthetist thought, what was the best medication management of these medications perioperatively, or the trauma and orthopedic consultants thought, and also what geriatricians thought. So there was a lot of back and forth. But after a few drafts, we finally came to a conclusion of something that everyone could agree on.
And how did you find sort of managing that range of stakeholders that you describe?
It was difficult. I think definitely as foundation year 2 doctor,
Yeah.
we were a bit low on the food chain, so to say. So I
Mm.
think it was important to get everyone's input, but also we had a registrar, orthopedic surgeon, who was on our team doing this, so she could get the orthopedic point of view, and as the doctors on the ward, we would get the view of the geriatricians. But it was quite difficult. But actually, what was really helpful, and actually that we were very lucky to see, was at the end the decisions were unanimous, and we didn't have to really argue about things, which is quite nice.
Yeah.
25 seconds left there, please.
Sorry, how many seconds? 30?
25.
25. Well, just what would be your key sort of learning point, and then that'll probably be a good place to end.
I think it's if you identify a lack of understanding and knowledge within your department, it's definitely important to pursue that. And I found that when I was clerking in patients, it was something that I was lacking in knowledge. And I thought it would be great to not only learn myself, but also teach others and make sure that we can keep this information within the department.
Brilliant.
That's
Thank you very much.
time. Thank you, Dr. Singh.
Thank you.
If I could ask you mute your mic, we welcome the next presenter, Jenna Sheldon, who will be presenting on improving efficiency and effectiveness of urinary catheterization at busy district general hospital.
Okay, good morning, everyone. My name is Gemma. I'm currently in FY1 at the Royal Free, where I undertook this project with one of my colleagues, the urology registrar, Becky Antonio. So a bit of background, first of all. 15 to 25% of admitted patients require catheterization. Inefficient or failed catheterization attempts have negative consequences, whether that's from repeated unsuccessful attempts, so urethral injury, infection, strictures, the distress it causes to patients while waiting, increased costs from more failed attempts, or taking away doctors from other important on-call jobs. So to assess the problem, first of all, I did stock checks of the non-urological wards, which revealed very poorly organised catheter equipment, with the biggest gap being in special types of catheters. We found out what the urology department felt about this, how they were impacted by questionnaires, with 100% saying that time is lost finding specialist equipment and that a urology on-call bag would be useful. We also did a foundation trainee questionnaire, which revealed low previous experience and confidence in catheterization. And then we also considered that difficult catheters can sometimes require emergency cystoscopy in theatre. So the aim was to improve the quality and efficiency of catheterization, ameliorate patient care, and save money for the trust in the process. So to do that, we implemented 3 different improvements. So we established urology on call bag, we did FY2 catheterization teaching, and we also established a single-use ambuloscope trolley to be used instead of patients having to be taken for emergency theatre. Next slide, please. So the outcomes and what we learned. So questionnaires demonstrated subjectively that 100% of the urology department agreed that the urology on call bag improved efficiency of catheterization. Foundation teaching revealed that confidence in catheterization improved, which was revealed by the pre and post teaching questionnaires. This also likely saved money with fewer failed catheterization attempts. And then in terms of objective measures, in 4 months, the ambuloscope saved £6,500 by preventing 11 patients from needing to go to theatre for difficult catheters. We worked this out from an estimated cost analysis. So these changes have both subjectively and objectively improved quality and efficiency of catheterization. Next steps can include patient experience, questionnaires, applications to other specialties, establishing these other trusts, making the teaching more regular. Unfortunately, it's very hard to gain objective data on the number of failed catheterization attempts for various reasons. And another consideration is that the ambuloscope is single use, so it's maybe not as environmentally friendly.
Thank you for that. Vardy, do you have some questions for the next 3 minutes?
Yeah, brilliant. Thank you, Gemma. Really good demonstration of use of PDSA cycles. And just wanted to ask you a couple of things, actually. So you mentioned towards the end that next steps would include patient experience. How would you go about that?
So I guess first of all, you maybe want to make a questionnaire to ask their experience, and then, I mean, logistically, it might be a little bit difficult, but if they had these questionnaires sort of on the ward and the nursing staff were aware, then when a patient did require catheterization or perhaps a difficult catheterization, then they can be offered this questionnaire to complete.
Would there be something specific in their experience that you'd be interested in relation to, to the aim of this project?
Yeah, I think it would be about looking at, obviously, having a catheter is not a pleasant experience. Having repeated unsuccessful attempts is even less pleasant. So I guess it would be to do with kind of if it was done smoothly, how long they had to wait. So for example, if you go in and none of the equipment's there and you have to go out again, find all the equipment, and then it's not even on the ward. And then, so that's the point of the urology on call bag. It's all there. You've got your special types of catheters. So if you go, think, the normal type isn't working, let's try a Teven tip. It's all there. You don't have to leave and go back with the patient possibly still remaining half undressed, which isn't nice for them either. So those are the kind of things, I think.
Yeah, that address the quality aspect of it. And then just about the bag, any thoughts or things in place so that bag remains well equipped, when you go on.
Yes. So the way we did it is that we spoke to the ward manager on the urology ward, and we spoke to her about ordering all the equipment, and then that was going to be stored in the urology stockroom. And then in terms of restocking the bag, partway through we actually got feedback about this, so establishing an inventory of stock so we know what's meant to be in it. And then at the Royal Free in the urology department, there are physician associates, and there's always a physician associate of the week. So whoever was that person that week would be in charge of restocking the bag. And then over the weekend, it would be the registrar or the F1/F2 over the weekend that will be in charge of that. So to make sure it all remains with all the equipment needed.
30 seconds left.
Great. And you made a really interesting point, I think, towards your presentation about the environmental impact of single use. Was there anything you wanted to say more about that? I suppose that's not within your control, is it? But
yeah, I think the thing is, on one hand, yes, it is single use, but then anytime you actually have to go into theatre, you're then using even more single-use
Mm.
things in that respect, or even more energy for all the various things that need to go on in theatre, sterilising the equipment, the cleaning
That's
after.
time.
So, okay,
Yeah.
thank you.
Brilliant. Thanks, Gemma.
Thanks
Thank
very
you.
much, Gemma. If you could mute your mic and we'll move on to the next presenter. Thank you. Next up is Sorka Hill, who will be presenting on Protecting Patients, a Quality Improvement Initiative for temazepam practices in primary care.
Yep. Can you hear me okay this time?
Yeah, all good.
Perfect. So, yeah, as Noah said, I'm Sorka Hill. I'm a final year medical student at Ulster University, and this was a quality improvement project I completed throughout a longitudinal placement in general practice with my GP supervisor. So the focus was on temazepam prescribing, which we worked to identify as an area of high risk practice in all primary care settings. But particularly across Northern Ireland, there has been a rise in benzodiazepine use and prescriptions, and the prescription rates are actually significantly higher in Northern Ireland than they are in other parts of the UK. And this has been backed by various service and accounts reports. So that was where the aim was achieved there. The aim that we set ourselves was a 10% reduction in the number of patients on repeat prescriptions for temazepam in May 2024, which would have been the end of our cycle. And if you refer to my poster, which I know is available to view, you can see the various process maps and fishbowl diagrams that were done, and that was with input from all of the wider staff body in the general practice I was in, to help identify the barriers and the contributing factors to how they got to this point of temazepam prescribing rates. And then again, work together to sort of make a goal. And as I was no longer going to be in the practice, we had to implement changes that the practice would be able to keep on, perhaps with help of other medical students once I had left. So we can go to the next slide now, Noah, please. So the interventions that we implemented did lead to a reduction from 41 to 38 patients by the end, and we were able to identify that the key strategies were on of the risks of long-term temazepam use, improving the coding on the IT systems so that everyone has access and visibility to the patients that are on temazepam and are at higher risk of complications and addiction issues. Conducting regular medication reviews with that patient group, and then providing patient education just across the board. In doing this, we realised the most sustainable change came from the better coding to flag those high risk patients and to focus on them primarily. And unfortunately, the multidisciplinary team involvement, which had seemed like a great
That is time.
strategy, was not so successful.
We can now have 3 minutes of questions.
Brilliant, thank you. I'm like desperately trying to find my unmute button. Great, thank you. And just to say, actually, I thought your poster was really well presented, and you really demonstrated a range of tools that you used to form part of your analysis. So yeah, just wanted to reflect that. I suppose a couple of things, and I think you started talking about the multidisciplinary aspect of it. So that sounds like it was challenging. Knowing what you've known now from the experience that you had, and thinking about future improvement projects that you might get involved in, what learning do you have about, I suppose, involving the MDT in projects, and how would you go about it?
So I think what would have been more useful and would help future would be before, in those very, very early stages when you're just figuring out your scope for the project and even the scope of involvement of other members of the team, is actually understanding what falls within this practice. So while that general practice did have a big team of mental health practitioners and other sort of psychologists, members and things like that would come in occasionally, it wasn't within their contract of work and their scope of practice where we're based to actually, take to do with prescribing practices and things like that. So realizing the limitations of the team you're working with and the area or the setting that you're based in, I think would have
Mm.
saved us heartache down the we really,
Mm.
unfortunately, with all the best intent, this portion of the MDT weren't going to be able to get involved to that level of patient reviews. And of course, their actual timing limitations and their own resource limitations. I think just establishing that early would have saved us quite some effort on.
Yeah, that's a really good point. So there's something about how interested people are and their level of influence that I think you're describing. You can have high interest but very little influence, and it's a balancing element there. And you also mentioned about, in terms of spread, about the potential to expand to neighbouring practices within the area. Any thoughts or ideas on how that would be enabled?
30 seconds
So
left.
yeah, as I mentioned, I think this would be most sustainable and easier to spread with the help of medical students being in general practice, as they have the time to do it. And I think initially spreading to general practices of a similar patient demographic would help before going to maybe more city practices with totally different patient demographics. This was more of a rural practice. I think that would be an important thing to consider
Sure. Yeah.
on that initial spread.
Yeah.
That's
So
time.
thank you. Thanks.
Brilliant.
Thank you.
You, Sorka. If you could do the same as before and mute your mic as we move on to the next presenters, who are Lucy Stiles and Ella Job, who are presenting on improving compliance with the use of transfusion-associated circulatory overload risk assessment checklist at a London teaching hospital.
Hi everyone, my name's Lucy and I'm with Ella today. We're both fourth year medical student at King's College, and our project was on transfusion-associated circulatory overload, also known as TACO, which is the leading cause of transfusion-associated morbidity and mortality. But it is very preventable if you are able to identify at-risk patients via a TACO risk assessment checklist. However, our baseline audit showed that of 92 transfusion events, only 27% were compliant with the electronic TACO checklist. Our root cause analysis identified that key issues would be lack of training and awareness, time pressure, and poor system prompts. And an anonymous survey of doctors showed that 79% of them had never received any teaching on TACO or the use of the checklist, and only 32% of them use the checklist consistently. It also highlighted haematology doctors and internal medicine trainees as key target audiences, and also teaching sessions as an intervention that would be easy to implement with fairly high benefit. So we had two PDSA cycles. The first was an online teaching session targeting haematology doctors and involved interactive case studies on TACO and the checklist. And PDSA 2 involved in-person teaching for IMTs and nurses with a practical focus and nurse involvement as an additional safety layer. Next slide, please.
So we measured overall checklist compliance post our interventions. Now, unfortunately, overall checklist compliance remained low, but active compliance, where those with positive risk factors were identified correctly on a risk assessment, significantly improved to 17.5%, indicating better clinical risk recognition. Now, when we analysed our post-teaching feedback, it showed that over 90% of participants found teaching improved their understanding of TACO risk factors. This indicated that the teaching was an important stepping stone in kind of like our whole picture of improving compliance. However, education alone was clearly not enough to change behaviour. So we thought about what could be our next steps based on our data and feedback. So we would like to propose embedding checklist prompts into EPIC, which is the electronic health record system in our trust, potential for exploring AI-driven alerts, behavioural nudges, and scaling our interventions with a national audit tool. In conclusion, while teaching specifically our in-person teaching targeted nurses helped raise awareness regarding the need to be more aware of TACO risk factors and their risk assessments. Thank you.
Thanks for that. And moving on to the questions.
Lovely. Thank you, Lucy and Ella. Yeah, really interesting, I suppose, point there in that, you focused on the teaching element of it, which sounds like a very natural thing to do in improvement projects. So if you had more time, and I think you were beginning to touch upon this, what would you do with regards to those system level changes in terms of, using improvement methodology?
I think it would be really great to kind of implement, as we said, kind of any sort of checklist prompts into the electronic health system. And especially with where data is kind of going at the moment, a potential for exploring kind of AI-driven alerts when patients have risk factors already listed in their problem list. If you then go to prescribe blood products, possible behavioural nudges that kind of suggest that this patient does need their risk assessment filled out correctly.
Yeah. I wasn't sure, Lucy, were you going to say anything to add? You might not.
Basically the same thing as what Ella said, yeah.
Yeah. And I mean, you're both fourth year medical students, right? Yeah. So what have you learned about doing an improvement project at this stage in your careers, and what will you take with you when you then do your next ones? What's your key learning, basically?
Yeah, I think it's been a really great learning experience for us doing this at such an early stage, kind of in our careers, I suppose. And I guess we learned kind of.
Hello. Yes. Assalamu alaikum.
Sorry. No, is just sorting that out.
That's all right, no worries.
You might be able to carry. Yeah,
that's fine. Yeah, so I think we learned all the kind of soft skills like organization, communication, teamwork. And I think we really underestimated the value of QI, especially kind of looking at what our colleagues have done and their projects, kind of the impact that it can have, but also patience, I suppose, and that you won't see changes immediately. And in fact, you might do a whole QI project and not see any improvement at all. But that in itself is actually valuable learning that you can then take forward to further projects. Yeah, I don't know if you want to share anything else, Ella.
No, that's pretty perfect, yeah.
Yeah, so that's interesting point. So about not always seeing the results fast enough because change takes time. And
30 seconds,
sorry, any thoughts? So you've got recommendations about what, if you were handing this over, what would you sort of recommend?
Yeah, so we are actually working on that at the moment. We have carried on the teaching sessions beyond the project, but we're working on kind of training up nurses once we kind of graduate and head off, that they'll be able to then kind of teach the sessions themselves and have autonomy over this kind of teaching beyond our involvement in this project.
Brilliant, that's great. Thank you both.
Perfect. Lucy and Ella, thank you both very much. Same again, if you could mute as we move on to the next presentation, please, where Dr. Lindsay Johnson and Dr. Philippa Sayers will be presenting on Ouch, This Hurts, pain-free prescribing, improving analgesia prescription following elective orthopedic surgery.
Hi, I'm Lindsay and this is Pip. And while we were F1s in orthopaedics in Greater Glasgow and Clyde, we noticed that 65% of our patients were being double prescribed analgesia. By double prescribed, we mean 2 prescriptions of paracetamol or paracetamol and cocodamol, 2 of the same strength opiates, or 2 NSAIDs at the same time. As F1s, we were dealing with the consequences of patients being overdosed firsthand and seeing the impact on patient safety. Between ourselves and other key members of the ward, we discussed the possible causes for the double prescribing and ideas to try and help and improve the situation. We aim to reduce our double prescribing by 80%. We formulated a protocol to help reduce the risk of double prescribing during clerking, which was done by the F1s and the AMP. It focused on us suspending admission medications that anaesthetics would also prescribe later. We worked closely with the pain nurse to ensure that by doing this, we weren't increasing her workload and have patients under prescribed analgesia in the process. In tandem, we looked to educate and encourage nursing staff to highlight prescribing issues, creating an area for them on our whiteboard to note down these errors if they found any. And we educated the wider regional orthopaedic department to allow for changes to be made by consultants from the consultants downwards. Next slide.
And so we achieved our aim. In fact, in the last week that we kind of studied, we had no patients at all with any double prescription of analgesia, while our balancing measures remain pretty stable. Obviously, this is something we're really pleased with, but I think there are still things that we'd do differently or change if we were to do it again. I think a major barrier we had was trying to get the anaesthetics team to engage. And in hindsight, sitting down with them prior to the project starting and discussing their insights into the issue might have enabled more buy-in from them from the off. It might have kind of increased the ease of the project and kind of improved the impact having senior colleagues on board from the start. And the positive thing, though, was we learnt how small, kind of easily implementable steps can have a really big impact on outcome. Like small changes allowed us to take on lots of feedback and to be adaptable. So the changes are kind of easily achieved and it's not as overwhelming for the team to bring them in. And I think we also found it was really rewarding that a project run by quite junior members of the team has had an impact at a kind of regional level in Clyde, prompting further discussion like from the consultants about prescribing practices in T&O in Clyde. And for me, I
That's
really
time.
oh, that's fine.
Wonderful.
Onto the questions.
Thank you, both of you. Medication is a hot topic. You'll see throughout all of the posters, so very topical. And just to a note that I made, and you said it already, is about what you were saying about small changes making a big impact collectively, and you've demonstrated that really well on that run chart that you've got on the screen there. And also just another reflection, really impressive how you evolved your aim with your stakeholders early on. So just to sort of say that's quite unique actually. But I wanted to just dig a little bit deeper in that. And wondered if you had any reflections on what the resistance may have been with the anesthetics, because you've reflected on that was a lesson learned, but any thoughts of why?
I think we talked about this quite a lot. I think one of the main things is, as an F1, it's quite hard to go up to an anaesthetic consultant and talk to them about their prescribing habits. So I think there's a sort of a cultural thing between sort of the two sort of stages in your career. I also think in terms of sort of positioning, we didn't really see the anaesthetists on the ward that often. They would come up, they would be there very briefly. So in terms of sort of us being on the ward, then being in theatre, there wasn't that much crossover.
Yeah, and I think that potentially we'd already identified an issue and came to them with an issue instead of coming to them and saying, how could we make this better, and kind of getting them in a more positive way rather than just saying, we think this is wrong.
Yeah.
Okay. Yeah, no, that's so valuable. Thank you for sharing that. So it's relationships and there's that power balance that you described. So on the graph, it's great that this project has kind of got to week 16 and you've got it to such zero, you got it to low levels. In terms of sustainability, what will be happening there beyond what are the plans or thoughts on maintaining that?
So actually,
30 seconds.
We've rotated, so the way that our hospitals work, we're spread across quite a few, so we've had to rotate out the hospital, but we have just returned to the same hospital, and we're here for 4 months, so we are going to go and re-audit the data and check whether what we did, which would have been about this time last year, is still sustained on the ward, and see if that's still ongoing, and we're in the process of doing that just now.
Fab. Okay, so there's a bit of monitoring, checking in, and then maybe revisiting some of the interventions. Yeah,
it may be that things have changed.
Yeah, brilliant. Thank you.
Thank you for that, Dr. Johnson and Dr. Sayers. Dr. Yap, you are presenting on greener inhaler, and you can take it away when you're ready.
Okay. Hello, my name is Jacqueline, and I'm a Foundation Year 2 doctor working in Royal Oldham Hospital. I believe most of you here agree that at least one of the patients you see in a day is on salbutamol inhaler. Yes, they are amazing in symptoms control, but they contain hydrofluoroalkane propellants, which are potent greenhouse gas, contributing to 3% of the NHS carbon footprint and 15% of the primary care carbon footprint. Amongst the 3 commonest brands of salbutamol inhalers in the UK, Ventolin Evohaler has the highest carbon emissions, followed by Salamo and Aramir. When I was in my GP placement, I noted that out of the 1,401 patients On the asthma register, 65 of them were on regular prescription for Ventolin Evohaler, while 266 were prescribed generic salbutamol inhalers without a specified brand, resulting in potential variation in the inhaler dispense at each collection depending on stock availability. This project aimed to reduce the carbon footprint of salbutamol inhaler by switching regular prescriptions of Ventolin Evohaler and generic salbutamol inhalers to Salamo. 3 PDSE cycles were conducted in this project. In the first cycle, I reached out to patients about the change in their prescriptions with an option to opt out provided. And I then created a poster to raise patient awareness regarding the environmental impact of Ventolin Evohaler and to encourage consideration of Salamo inhaler. In the last cycle, I successfully increased healthcare professionals' awareness of the carbon emissions generated by inhalers through a teaching session. Next slide, please. So the project led to a 71.3% reduction in patients on regular Ventolin Evohaler and generic salbutamol inhaler prescriptions, dropping from 24% to 6.8%. PDSE Cycle 1 drove the most impact, while Cycle 2 showed minimal change. Cycle 3 effectively raised self-awareness of greener inhalers. However, the short project duration limited assessment of long-term impact, highlighting the need for extended data collection and potential further PDSE cycles. Thank you.
Perfect. Thank you very much, Dr. Yap. 3 minutes of questions. You can take it away, Vadi.
Thank you. Thanks, Jacqueline. Really, again, really interesting and topical project to be looking at clinical practice through the lens of sustainability. So really, yeah, great to see that. So yeah, as you were saying, that sort of contact with patients, PDSA1 has had the biggest impact, made the biggest difference. In terms of sustainability, how will that be maintained?
So I had a chat with my supervisor by the end of the last cycle, and then we thought about, given that patients are on regular sort of asthma follow-up, and during that follow-up, so we can mention it to them, if let's say they are either on Ventolin Evohaler or regular salbutamol prescriptions, we can let them know that we are thinking about changing it to Salamo if they are not already, and we can let them know the reasons of that. So I think, yeah, if we look into sort of doing this during those follow-up checks, we can sort of maintain the cycles.
Okay, so yeah, it's those follow-up interactions, hence the importance of kind of maintaining that awareness amongst the MDT team who might be involved in that follow-up to have those conversations. And then I suppose I was just sort of thinking, so even though in this example, your PDSA2, like the posters and the public awareness, didn't have as much of an impact because PDSA1 had such a big impact. I suppose, how important do you think that public awareness is? And are there other ways that might be considered on maintaining or keeping that awareness? Because it might be a patient in the future that asks about this as opposed to being asked in a follow-up.
Yeah, so in PDSE Cycle 2, I created a poster, stuck it up on the wall, which didn't really create any impact. I think it was a really small poster, so reaching to patients in the waiting area, the distance is quite far, so potentially no one actually went up to look at the poster. So there is actually like a TV at the patient waiting area. So what I could have done was to actually upload that poster on that television. So when they're waiting and sitting in the area, they can actually look at it. And I think if
20 seconds.
If I want to focus on reaching to patients outside of this GP surgery, we can potentially think about maybe putting up posters in like supermarkets and stuff, sort of try and raise awareness. But I presume that would be quite hard.
Yeah, and that might be going out of your sphere of control of the project, like out of scope.
That's time on the questions. Thank you both. Thanks very much, Dr. Yap. Again, if I could ask you to mute your microphone as we move on to the next presentation from Lucy Colling, reducing the numbers of missed medication doses within the renal wards. And whenever you're ready, Lucy.
Thank you. So, hello, my name's Lucy, and I completed the following project, reducing the number of missed medication doses within the renal wards, alongside several colleagues at New Cross Hospital. The project began back in April 2023, following identification during reviewing drug charts that many patients were missing doses of important medications. This poses potentially serious risks to patient safety, including ineffective treatment, clinical deterioration, and prolonged hospital stays. We set ourselves the aim of reducing missed medication doses per patient per day for inpatients on the renal wards by 20% over a 6-month period. Following our initial data collection, we identified 2 common reasons for missed doses, the first being patient refusal and the second being drug unavailability. We decided to focus on the latter as an area of improvement. We developed 2 interventions which we implemented over 2 PDSA cycles. The first was a poster detailing a flowchart of actions for our nursing colleagues to take when a prescribed drug was not available in the drug trolley. The second was a slide shown to doctors during their local induction, which reinforced good prescribing habits. Next slide, please. So what were our results? Following the educational intervention, the overall rate of missed medication doses reduced by 22%. Medications missed due to drug unavailability reduced by 9%. After a 3-month period of sustainability, a further data set was collected. This showed that overall improvement in numbers of missed medication doses was unfortunately not sustained, but the number of doses missed due to drug unavailability continued to improve, with an overall improvement of 29% seen. The remaining increase in drugs missed seemed to be driven by patient refusal of doses. Moving forward, this would be a key area for us to investigate further. We learned a lot during this project, particularly surrounding MDT involvement. We involved doctors of all levels, pharmacists and nursing staff at multiple stages of the project, from both exploring their ideas behind where things were going wrong and also in targeting interventions to improve things. A particular challenge identified was the potential success of targeted interventions in the face of rotational physicians. We would like to further explore how a lasting impact can be made in the face of such a reality. Thank you.
Fantastic. Thanks very much. And moving on to the questions again.
Yeah, thank you, Lucy. You know, really, a really well executed project, and your first slide showed, and you had it on the poster as well, the intervention following each PDSA cycle. So the intervention was informed by what had happened previously. So, you know, brilliant. And really interesting point there about how one of the things to explore further was the sort of patient aspect of it and the refusal of medication. Any thoughts on how that might, you know, if you had more time, on how you would go about that in a way that doesn't make patients feel defensive?
Yeah, definitely. I understand that, because we don't want patients to feel like they have to take medications. It's their choice at the end of the day. From we've not looked into this properly yet, but initial kind of looking through the types of drugs which were refused, a lot of them were things like analgesia and laxatives, which could be quite appropriate refusals on behalf of the patients. But there were some other ones which were a bit more concerning, so things like antibiotics and electrolyte replacements, which do have the potential of causing some nasty side effects. So we wanted to start off with maybe getting the nurses, when they write patient refused on the drug chart, if they could kind of document a bit of a reason as to why the patient's refused. And also kind of encouraging doctors, when we're doing kind of our ward round preparations, looking through those drug charts, noticing when patients have said refused, and then whilst reviewing them, kind of asking them questions about it, and then kind of putting some educational things in there as well. And then hopefully, if there's any kind of particular areas which are commonly refused, try and implement some kind of posters for patients, patient leaflets, things like that.
Yeah, brilliant. Yeah, it's really interesting. And in case you didn't listen to it, there was a really interesting talk this morning, the second speaker, to do with listening in medicine, that a lot of this fits into what was said there. So if you got the recording, do sort of watch it. And So now I'm like trying to think of my next question. Um, So oh yeah, about the rotating staff. So that's like a really common theme in
Yeah.
a lot of the projects. I mean, I know there's no magic solution to that because that's the nature of the business.
Yeah.
But any thoughts on that, on how we take that into consideration in how we work?
Yeah, it is very difficult. So one of the things we thought of was maybe kind of instead of just having our intervention in a slide in induction, making that more of a poster above where the doctors tend to work on the wards, just so it's more of a constant reminder and can be transferred between doctors. And also trying to implement that into our online prescribing system. So having prompts where you give kind of stat doses of things, kind of reminding you to go and tell the nurse there and then if they can give it, and prompting you to.
That's time on the questions, I'm afraid.
Thank you.
Great, thank you, Lucy.
And then thank you, Lucy. If I could just ask you again to mute your mic as we move on to the next presenter, who is Dr. Connie McCafferty, presenting on a resident doctor's ENT handbook. And whenever you're ready, Doctor.
Hello everybody, my name's Connie. I'm an F1 doctor at New Cross Hospital. So ENT is a relatively niche specialty, and I think there's a general lack of exposure to ENT specific skills and presentations across multiple hospital specialties. So before we started the rotation, there was no prior learning material provided to familiarise ourselves with the basic roles needed for the job and skill set. So I developed a questionnaire and sent this to resident doctors prior to starting their rotation with the aim to assess confidence levels in the core areas of ENT. So looking at the results, it showed a general lack of confidence in the majority of areas assessed, particularly ENT specific skills and managing emergency situations. And I think that's something that's very important to have at least a basic knowledge of before starting looking at it from a patient safety point of view. So I developed a resident doctor's handbook to improve baseline knowledge, and I've listed the general topics that were covered in this handbook. I then distributed it to resident doctors starting in ENT, along with a further follow-up questionnaire to assess the effectiveness of the handbook. Next slide, please. Looking at the results, the use of the ENT handbook led to a significant increase in confidence levels prior to starting the rotation in all areas assessed, and 100% of participants would recommend the handbook to future resident doctors in ENT. The feedback showed that they'd like a skill session alongside the written material due to the practical nature of the specialty, and that's in place now. Looking at a plan going forward, the handbook's now being circulated to all future ENT doctor cohorts, and there'll be a review of the handbook content in 1 year to ensure it's up to date with current medical and local guidelines. Reflecting on the quality improvement project as a whole, I think it's really highlighted the importance of a collaborative approach to ensure the accuracy. So that involved me directly liaising with consultants and senior doctors to get their feedback on the content and if it was relevant. And then I think if I was to do it again, I could include a more objective outcome measure, such as that time taken to complete tasks, error rates, direct senior feedback, and maybe gather MDT feedback from a broader perspective on what juniors need to know and what could be included. Thank you.
Nice time. Perfect. Can we move on to the questions?
Yeah, thank you, Connie. And again, it's another example of the challenges of rotation in medicine and the transfer of information. So, really important piece of work. And you made your last point there about a more objective measure. Is it? I suppose is this project being handed over, or is that something that could follow on from this original piece of work to supplement, the subjective data that you've collected?
Yeah, it's definitely something that I could either continue myself or hand over to future colleagues in the department. Obviously, at the moment, we've used a very objective measure, looking at confidence levels. So looking at a more objective measure, like time taken to complete tasks, I think it would be really valuable to get a more accurate picture. But definitely something I could look at continuing in the future.
Thank you. And who So you've said in that the future is that the content will be reviewed in a year, and I suspect, you know, that will sort of follow on. Who owns it? Who would sort of take charge of that?
So I've sort of taken charge of the project myself, along with my supervisor from the ENT department. So I think in a year's time, we'll both sit down together and look through the handbook and check the content, check any updated guidelines, and make sure that all fits with current guidelines. So it's something we'll do ourselves.
Okay. And beyond that, or you know, in
Yeah.
5 years' time, just
Yeah,
like
beyond that, it could definitely be passed on to somebody else. I can discuss with future colleagues going into ENT, maybe looking at the ACPs that work on the ward. They're more permanent members of staff within the department. So it might be something they can take on if they're more permanent there. Definitely something to look into.
Lovely, thank you. And then just with your data, I mean, on that graph, it shows a pretty even sort of spread in all those different facets, I suppose. The level of starting, you know, confidence to start with, and how much it improved. But as you were sort of dealing with the data and looking at it in more detail, were there any themes or anything that struck you of interest? Yeah.
30
Yeah, it was
seconds.
generally the lack of confidence in, I think, emergency situations. And I think that was a really big thing to highlight, because sometimes when you're managing patients on the ward, you might be the only doctor there. So having that basic knowledge on how to manage the emergency situations is really important for patient care. So I think that lack at the beginning was something that would be really good to improve before doctors start the rotation.
Right. Yeah.
That's
Brilliant.
fine.
Thank you.
Thank you.
That's great. Thanks, Connie. Same again, if you could mute your mic, and we will move on to Ruby and Newton, who will be presenting on the good, the bad, and the ugly. Use of a care bundle reduces surgical site infection after all grades of contaminated emergency laparotomy.
Okay, hello, good afternoon. Newton. I'm presenting this on behalf of a team of diverse healthcare professionals. We did the quality improvement project that aimed at reducing surgical site infection after emergency laparotomy. An emergency laparotomy is an operation that is done on the abdomen. And usually during these operations, the wound is often dirty, contaminated, either with feces or pus. We previously had implemented a care bundle after elective bowel surgery, which had halved surgical site infection. So what we have done in this project was to implement an adapted care bundle to reduce surgical site infection after emergency laparotomy, and to assess whether this was effective at all degrees of contamination. The surgical site rates were measured continuously for 4 years. It's been done since 2019, and we used the National UK Health Security Agency Wound Healing Questionnaire at 30 days post-op. However, we noticed that a significant number of patients after emergency laparotomy were still in the hospital after 30 days, and for them, we used the in-hospital surveillance. The care bundle, as shown in this slide, you could see it consists of 2% chlorhexidine, antibacterial sutures, wound protectors, and a second dose of antibiotics after 4 hours. What we did was the additional elements were gloves change and betadine wound wash. We measured compliance with all bundle elements in theater, and this is as shown in the lower left hand of this slide. We had a good compliance with all the elements except for wound protectors, and we had a good questionnaire response rate of 65%. Next slide, please.
Our results table here shows that we significantly reduced overall SSI rates from 34.3% to 19.9% after the intervention. Wounds were classified into clean, contaminated, or dirty. Clean surgery is when the wound is not contaminated at all and there is no breach of the bowel. Clean contaminated is a bowel operation with controlled entry into the bowel but no gross contamination. And dirty procedure was when there was a perforation of the bowel with gross contaminants such as pus or feces. As you can see, the bundle reduced SSIs overall, and this was most significant for dirty wounds. in summary, this is the largest study of SSI following emergency laparotomy in the UK at the moment. We significantly reduced.
Apologies, move you on to the questions now.
Lovely. Thank you, both of you. So this is a really good example of a project that's been sustained over a really long period of time, and also another reflection. Great to see how an existing intervention has been, adapted over that time as well, and that, and your measurement sort of has continued on with it, of its impact in that way. So I have a question actually. What keeps you motivated to continue with this project over that period of time?
Yeah, I think our consultant who's overseeing the project feels really passionate about the issue and is involved in lots of projects. So we've got involved over the last year or so. So yeah, continuing to try and improve the SSI rates and to kind of move the project forward. The next stage we're about to implement is the use of a new antibacterial dressing. So we're hoping to collect more data on that and see how that affects the results.
Yeah. Brilliant. And that is actually, that does lead into sort of what next. So you've got the dressing, and any sort of predictions or thoughts about what impact that will have, on the rates. Like if you were to write an aim statement, like what would the aim be? Would it be to reduce it by a further 5%, 10%? Like what?
Yeah, I think we've got some preliminary data already from the new results, which has shown a good decrease so far. We're hoping to reduce it, kind of comparing with national data and keeping in line with the current rates as well. Yeah.
Okay, so it's kind of informed by two things: early data and national data as well, of what you'd be aiming for. And I suppose after you said you've both been working on it for the last year. How will it be handed? How will you find new people when you move on to continue this work?
Yeah, I think there's a really good kind of core team of people who have been working on the project. So as I say, our consultant, also the theatre nursing staff, the advanced recovery nurses are all like core
30 seconds
who are staying at the hospital. And yeah, like myself and Newton in a kind of rotatory capacity. Newton's more permanent than me, so yeah, he's hoping to stay on as well.
Fab. Brilliant, thank you. And Newton, were you going to say something else?
No, she said took the words out of my mouth already.
Brilliant, thank you both.
Thanks.
Perfect. Yes, thank you both. Again, if you can mute your mic as we move on to the next presentation, which is from Dr. Viren Pandya, who will be presenting on promoting physical health confidence in Barnet early intervention in psychosis service.
Hi, my name's Viren. I'm an FY1 doctor at Barnet Hospital. So physical and mental health are intertwined. Despite this, mental health trusts remain relatively under-resourced in their ability to provide physical health intervention. And this leads to reduced daily staff exposure to physical health, and in turn, a workforce which might be undertrained, de-skilled, or lack confidence in physical health and actioning it in their patients. So to find out whether this was a problem, I surveyed my local early intervention in psychosis service and the wide-ranging MDT within that, and found that the baseline confidence was 6.39 out of 10 in recognizing and actioning physical health in their patients. In addition, only 45% had refreshed their knowledge of physical health in the last year, and almost 40% had never had physical health training. So we created a smart aim to increase the self-rated physical health confidence by 0.5 over a 3-month period in our MDT. And this is in keeping with the North Central London Longer Lives strategy. So we gathered many change ideas and implemented these in our 2 PDSA cycles. The main intervention was bite-sized weekly teaching as part of our multidisciplinary team meeting. And we introduced this around a hypothetical patient case. Our second PDSA cycle built upon this and introduced in-person simulated patient scenarios as well as SBAR handover training. Next slide, please. The main outcome from our project was a 1.81 point increase in self-rated confidence over a 3-month period, which was equivalent to a 28% increase. What was most intriguing was that 93.3% said that teaching has or will affect their clinical practice. And in addition to this quantitative data, we gained some qualitative data showing the enthusiasm and how much the project had impacted the individuals within the MDT. And you can see that in the box below. So overall, what we learned was that regular bite-sized teaching and consolidation can improve the confidence of a diverse multidisciplinary team in recognizing and actioning physical health, with an impact on patient care, which we then anticipate will also impact patient safety. It shows that protected time for continuing professional development is really vital. And one key thing is the lasting impact this project has had. I'm really proud to say that teaching in the department is ongoing, and now it is led by the MDT. So thank you very much for your time, and I'll take any questions.
Perfect. On to the questions.
Great, thank you, Varan. Two observations that I want to share. Your driver diagram is excellent, really good quality, and well detailed. And the second thing, and I suppose this is also a bit of a question, like it was really impressive in this work, the variety of different teaching interventions, from bite-sized to intervention to online sort of self-directed learning. How were you in the project team able to do that? Do you have specialist teaching or education knowledge?
No, not per se. We were just really enthusiastic about teaching. And I think as I'd gone through medical school, I loved these kind of short, bite-sized nuggets of knowledge which we got delivered, and I wanted to kind of impart that onto the team. And what we actually showed is the team loved it too. So they wanted more teaching. They wanted to contribute to teaching. And the fact that that's happening now is really exciting. All the different interventions came from our driver diagram. We thought, what could we possibly implement within the team that would be sustainable? And I think the presentations was the first thing that we found sustainable. And on top of that, the in-person setting, when the team does come together in person, we wanted to find a way we could teach in that setting as well. So we thought of loads of different options and implemented a few of those so far.
Yeah, brilliant. Yeah, that really stood out. You said in think sort of the conclusion and what you learned, along with the results, that you've achieved, that element about that you anticipate that it will impact patient safety. Would you be able to say more about that? Like what kind of things are you sort of anticipating?
Yeah, so this team, every member of this team is patient facing. And so everyone has a responsibility for recognizing and actioning physical health within a mental health patient as well. And it's part of this longer life strategy in our local trust. And for that reason, I think it's really important that knowledge is up to date and knowledge is shared amongst all of these diverse multidisciplinary professionals. So you have social workers, mental health nurses, dietitians, employment advisors, lots of different professionals, but they all see patients. So it's really important that they recognize these signs and symptoms in their patients so that they can flag it up to another professional and really make sure that they can improve the safety of the overall demographic. And I think that's why it's important from a safety perspective.
Yeah, brilliant. I suppose you've probably only got like 10 seconds. Any lasting insights that you've had from doing this?
I think what I'd say is enthusiasm is infectious, and we saw loads more QIPs launch in the department after sharing this one, and everyone was getting involved in the teaching. It's really quite it's a really nice legacy in a way, and I think that it just shows that QI leads on to more QI. So yeah, that's my point.
Thank you.
Thank you.
Thank you.
Perfect. Thanks everyone for your poster presentations this morning, and big thank you as well to Vardeep too again for being our judge. It is now lunchtime, so you can take a break, but please do be back at the stage for 1:10 to hear Rhys Haddon, barrister at Sergeants in Chambers, his talk on Gillick competency, children and consent. Thank you again.
Brilliant. Thank you, everyone. Thanks for your time. And thank you, Noah.
No problem.